some of the teeth are showing rotations, or some of the teeth are showing spaces, or you find there is class 1 malocclusion, there is class 1 molar relationship that is normal, and you find there is no rotation, no spaces, but some of the teeth are showing negative inclinations, means they are not in normal position, they're not showing normal occlusions. For example, in the first picture you see here, in the first picture you see here, the upper incisors. What do you see here in the upper incisors? In the first picture in this slide, what do you see about the angulations and inclination of these incisors? Can anybody please tell me what do you see here regarding the second key of the third key of occlusion? The third key of occlusion. Yes, exactly, Nasir. The wrong torque means gingival portion is labeled to the incisal portion. Ideally, it should be lingual to the incisor portion. Am I right? So, but this picture is showing negative torque. So, even if the molar is class 1, there is no rotations, there is no spaces, cover speech flat, mesiodistal angulation is there. But if you find this point negative, it means it is not normal occlusion, it might be a malocclusion. And what is malocclusion? The deviation from the normal occlusion in one or more ways. There may be one key or different keys are not in normal position. They are showing the deviation from the standard, ideal, or you can say normal physiological occlusion. Right? So I'm not going into details of the development of occlusion here. I hope Dr. Shaheen already discussed it during the development, growth and development. Normal occlusion we discussed, malocclusion and its classification will be discussed by Dr. Ibrahim, right? So I'm not going in the details how we assess the malocclusion, right? What is the angles classification of malocclusion and occlusion class 1, 2, 3? If anybody wants me to explain this class 2 or 3 right now, I can explain in brief, but I'm supposed to talk about etiology today. Does everybody know what is class 2, class 3 molar relationship? What is class 2 and 3 canine relationship? What is class 2 and class 3? Great. So we will go directly to the malocclusion, etiology of malocclusion. Can please anybody tell me what could be the cause of malocclusion? What are the different causes of malocclusion? Yes, bad habits like sleeping late, watching movies. What else? Loose teeth. In what terms? Yes, the bad habits means thumb sucking. You should explain. Bad habit means thumb sucking. Exactly. What kind of malocclusion? Genetic. Exactly. What kind of malocclusion thumb sucking can cause? What kind of malocclusion is caused by thumb sucking? Open bite. Exactly. What else? Increased overjet, increased inclination of the interior teeth, cross bite, right? In addition to the open bite, yes, increased overjet. Exactly. What else? What are the other habits that can cause occlusion? Premature loss of the teeth. Yes, it's one of the causes of malocclusion. Exactly. What else? Extractions due to the decayed teeth, mouth breathing. Exactly. What kind of malocclusion a mouth breathing could cause? Again, the open bite, right? Cross bites, long face, adenoid faces. Yes, good. So there are certain specific causes of malocclusion, genetic causes, and etiology in contemporary perspectives, right? So disturbances start right from the beginning: embryological development, skeletal growth disturbances, muscle dysfunctions, acromegaly, disturbances of dental development, environmental influences, functional influences, etiology, contemporary perspectives like changing views of etiological possibilities, etiology of crowding and malalignment, etiology of skeletal problems. So we will be discussing every point in a little detail. So if we talk about specific causes in the embryological development, range from genetic disturbances to specific environmental insults. What is a teratogens? The chemicals and other agents capable of producing embryological defects if given at the critical time, right? So teratogens are the cause of these malocclusions, development of malocclusions. If you see here, there are so many chemicals which are given at the critical time. They can cause certain defects. For example, most commonly used drug aspirin can cause cleft lip and palate. Cigarette smoking, that is the cause of hypoxia, which is the cause of cleft lip and palate. Cytomegalovirus, ethyl alcohol, right? X-ray radiation can cause microcephaly. Valium, the diazepam, the antidepressant drug or sleeping drug and anti-anxiety drug can cause cleft lip and cleft palate. Vitamin D excess even can cause premature suture closures, right, resulting in microcephaly, small skull. So these are the teratogens which can cause the defects during developmental period. This is also thalidomide is also one chemical usually prescribed to pregnant women to combat morning sickness. When taken in the first trimester, it can cause various defects like short limbs, hemifacial microsomia. So this drug is banned in 1960s. Hemifacial microsomia, as the name suggests, hemifacial, half-sided, right? And the lower, for example, the lower half of the face, most commonly the ears, the mouth, and the mandible is affected. Fourth week of intrauterine life, the vascular problems leads to clotting and a poor supply of blood to the face, resulting in hemifacial microsomia. Skeletal growth disturbances, Pierre-Robin triad or Pierre-Robin anomaly or anomalet results in severe maxillary deficiency. Skeletal growth disturbances, they are caused by fetal molding and birth injuries, intrauterine molding, pressure against the face, or birth trauma to the mandible using because of the forceps used in deliveries. There is condition which is results in maxillary deficiency at birth, very common, and this is because of the fetus head is flexed tightly against the chest in uterus, preventing the mandible from growing forward normally. It results in maxillary deficiency, and it is related to why the fetus head is flexed tightly against the chest due to the decrease in volume of amniotic fluid which is required for the proper positioning. So it results in extremely small mandible at birth, usually accompanied by a cleft lip, cleft palate. This is also known as Pierre-Robin triad. Childhood fractures can result in malocclusion in later stages, which is usually gone unnoticed. These are the fractures because children bone is very flexible. It's like a green stick fracture, which is not very painful, gone unnoticed, and can cause problems in the later development. Here you can see the fracture of the right condylar process at the age 2, and the symptoms are showing now in the later stage with the mandibular deficiency and deviation of the face towards the site where the fracture happened. Muscle dysfunctions. The muscle atrophies when its motor nerve supply is lost, results from the damage to the motor nerve. It can cause excessive tonic contractions of the neck muscles on one side, primarily the sternocleidomastoid muscle, resulting in facial asymmetry. Right? The condition is known as torticollis. Torticollis. The cause is damage to the motor nerve, right? And the result is underdevelopment of the part of the face. Facial asymmetry can happen because of this condition. And this is because of the injury to the motor nerve during developmental periods. One of the conditions, also known as acromegaly and hemimandibular hypertrophy. As you can see, one side of the mandible is growing long. The cause is anterior pituitary tumor. The result is secretes excessive amount of growth hormone, excessive growth of the mandible resulting in long mandible. Even if the tumor is removed, the skeletal deformity persists and the jaw surgery is required to correct the size of the jaw. One of the conditions is also known as ectodermal dysplasia, is characterized by the presence of thin sparse hair throughout the body, the skull, the eyebrows, you can see, right? And an absence of sweat glands. So the skin will be scaly and dry. In addition to this, hypodontia is evident. So the condition is known as ectodermal dysplasia. As the name suggests, the problems are seen in the structures which are formed by ectoderm, right? The teeth, the hairs, the sweat glands, which are ectodermal derivatives, are affected. So if you find a patient in your clinics with hypodontia, you should check the hairs of the patient, the appearance of the patient, the eyebrows, the skin. If you find thin, sparse hairs, missing eyebrows, check other structures as well. Check the hereditary characteristics, genetics, other siblings. You might find this condition in hypodontia patients. It's not very uncommon. Disturbances of dental development, congenitally missing teeth, malformed or supernumerary means extra teeth, fusion or geminations, fusion, teeth with separate pulp chambers joined at the dentine. Gemination is what? Teeth with a common pulp chamber. You must have read all these in oral pathology, oral diagnosis. The terms used for congenitally missing teeth are anodontia, oligodontia, and hypodontia, right? There are three different terms. Anodontia means total absence, complete absence of teeth in the extreme form. Oligodontia is refers to congenital absence of many but not all the teeth. And hypodontia, absence of only few teeth. Oligodontia and odontia are rare, but hypodontia is relatively common finding. What are the teeth usually missing in hypodontia cases? What teeth you have find in clinics which are missing in hypodontia patients? I hope you people are still alive with my boring lecture. If you are still alive, please respond. Thank you. So only Nasir and Naif are alive and all are gone. What other teeth you usually find missing behind the lateral incisors? Which teeth you find missing usually? Canines, yes. What else? Premolars. Which one? Mandibular or maxillary? What else? Usually the mandibular premolars are more common than maxillary premolars. Third molars, exactly. So the disturbances of dental development, interference with the eruption, right? Teeth might be present, but they are not erupted because of the interferences. This is one cause. Supernumerary teeth might be there which are hindering their eruption. sclerotic or dead bone, thick bone, heavy fibrous gingiva due to trauma or something else due to development, hindering the eruption of the teeth. 5 to 10% has at least one primary molar ankylosis. That's a large percentage. Ectopic eruptions most likely occur in upper first molars. Early loss of primary teeth, premature loss of primary canines or primary first molars, distal drift of the incisor. These are the causes of disturbances in dental development. Forces from active contraction of transeptal fibers in gingiva, pressures from the lips and cheek, abnormal habits, bad habits. The pull from transeptal fibers probably is more consistent, contribute to the space closure tendency, whereas lip pressure adds a variable component. Traumatic displacement of teeth is one of the causes of malocclusions, damage to permanent tooth buds from an injury to primary teeth. Right at the stage of primary dentition, usually kids have trauma which results in damage or displacement of the permanent buds, which becomes obvious later in life due to uneruption of teeth, unerupted teeth, or ectopic eruptions, drift of permanent teeth after premature loss of primary teeth, direct injury to the permanent teeth. Genetic influences inherited in two major ways: disproportionate jaws, between the size discrepancy between the size of the jaw and size of the teeth. Sometimes the jaw size comes from the father and teeth size comes from mother, resulting in spacing. Sometimes the size of the teeth are bigger than the size of jaws, resulting in crowding. Or there is one more example which is related to royal family, European royal family known as Habsburg jaw. Prognathic mandible is one of the examples of abnormalities due to genetic influences. Now comes the environmental influences, the habits, thumb sucking, tongue thrusting. As you explained, thumb sucking, what happens during thumb sucking? If the thumb sucking persists after 8 years of age, it results in open bite, flared and spaced maxillary incisors, lingually positioned lower incisors. What is the relationship between the thumb sucking and lingually positioned lower incisors? I can understand the flared and spaced maxillary incisors due to thumb sucking. What is the cause of lingually positioned lower incisors due to thumb sucking? Not exactly the tongue. What else? If you see the kid who has thumb sucking habit, what he does usually is thumb is forcing the maxillary anteriors forward, whereas the rest of the fingers, the little finger, is usually rest on the labial surface of the lower incisors, resulting in lingual position of the lower incisors, whereas they push maxillary incisors in the labial direction, leads to spacing and flared incisors. Is it clear? The position of the fingers during thumb sucking habit results in labial inclination of the maxillary, whereas lingual position of the lower incisors. Anterior open bite. Why anterior open bite happens during thumb sucking? What is the cause of anterior open bite and a narrow upper arch? The narrow upper arch is actually caused by what? Because of the negative pressure created, because of the negative pressure created by the lips and the cheek towards labial surface of the alveolar process, resulting in narrow arch crossbite, and the position of tongue, it goes downward, right? It goes downward and results in open bite and the narrow arch. So normally the palate is dome shaped. It is formed during development because of the position of the tongue. Dorsum of the tongue rests in between the two palatal shelves, helps in the development of the palate in an arch form. dome form. During thumb sucking, what happens? Due to the fingers inside, tongue goes down, and the negative pressure from the cheek from the outside results in abnormal development of the palatal shelves, resulting in narrow arch, which leads to crossbite. See, the negative pressure is created within the mouth during sucking. Arch form is affected by an alteration in the balance between cheek and tongue pressures. When the thumb is placed between the teeth, the tongue is lowered, which decreases pressure by the tongue against the lingual of upper posterior teeth. At the same time, cheek pressure against the teeth is increased. Cheek pressures are greatest at the corners of the mouth. Maxillary arch tends to become V shaped with more constriction across the canines than the molars. Mouth breathers, they also result in adenoid faces. Nasal obstruction can cause mouth breathing at night, especially at night. Results in abnormal tongue position, which leads to anterior open bite and results in tongue thrusting as well. So, tongue thrusting is actually a misnomer, an abnormal term, right? It's not a right term exactly. Tongue thrust swallowing, right, is not a right term actually, but it can cause. What do you think? Tongue thrusting is a cause of open bite or an effect of open bite? Who will tell me? If you tell me the right thing, I will finish the lecture right now. No next slide. If anybody of you, so is it a cause of open bite or an effect of open bite? Knife is saying it's not a cause of open bite. Tongue thrusting is a result of open bite. Can you please explain how? Can you please explain why tongue thrust is considered as an effect of open bite and not the cause of open bite? It could be a cause, but in very vague terms. Why it could be a cause if the tongue position or tongue size is very large? Yes, when there is a more space, it results in tongue thrusting because, yes, exactly. Open bite causes a space for tongue thrusting. Why? Because in normal swallowing, if you try to swallow with your teeth open, can you swallow? Is there anybody in the class right now who are listening to me can swallow without closing the mouth? Keeping your mouth open, try to swallow. Is it possible? No. Why? Because you need to have an anterior stop. You need to have an anterior stop, right? To have a normal swallowing pattern, you need to have an anterior stop, which is done by normal overbite. If there is an open bite, there will be a space. So tongue comes forward to make a seal to create normal swallowing pattern. That's why tongue thrusting is considered now as an effect of open bite and not the cause, but it is not considered as that it couldn't be a cause. It could be a cause, but if the tongue posture is abnormal from the start of swallow, if there is a habit of patient that he or she keeps her tongue anteriorly than normal during the start of swallowing, it could cause a pressure and result in open bite as well. So tongue thrusting can be a cause if the size of the tongue is too large or the position of tongue is abnormal during the start of swallowing. Otherwise, it is considered as an effect. So, the etiological agents are usually no longer present when growth is completed. Whatever the malocclusion, it is nearly always stable after growth has been completed. If an orthodontic problem is corrected in adult life, a surprising amount of change is also stable. This ends this topic here. If you have any questions, you are free to ask now or anytime whenever you want. next week in your lab sessions. I'm available to answer any of your questions. I hope I made myself clear. You're welcome. Okay, thank you very much.